Born and raised in Australia, but Chinese, but citizen of the United States now, but also a citizen, so I have two passports, Australian passport and a US passport. When I got out of my psychiatric training in the Boston area, I was assigned to a treatment team in a fairly large inpatient psychiatric unit where we had 4 teams, 2 adult teams, an adolescent team, and an addiction treatment team. And they couldn't get anybody to work on the addiction treatment team, and I was the new kid on the block just starting out, so that was my assignment. Getting on-the-job training then around addiction treatment, being on that team, not because of my exquisite knowledge about addiction treatment, but because they couldn't get anybody to work there. So really got into addiction treatment through the back door of on-the-job training with counselors being my kind of mentors, as it were, but also getting my own interests because my addiction patients would get better and turn their lives around much more quickly than my schizophrenia patients and personality disorder patients and others who, you know, you could help, but you could really help people with addiction treatment. So this is in 1977. I got out of my training in 1977. So I've been at this now for, what is that, 38 years or something. And found that more and more I enjoyed working with addiction treatment than general psychiatry. Also, though, you could combine sort of spirituality with mental health, with addiction treatment, something that's not as easily done in general psychiatry. And that was an attraction as well. But I think mainly seeing people's lives turn around so quickly was fascinating. Well, I'd been raised in a fairly fundamentalist Christian church, and our family was very involved, and quickly learnt that 12 steps of AA, and we were very AA oriented, was knowledge not just for addiction treatment but really in life, sort of the paradoxes of letting go, of actually surrendering to become more empowered. That whole paradox, you know, a truth stood on its head so you don't recognize it, and saw the wisdom of that in life in general, you know, the serenity prayer, and really seeing how people who were trying to control their lives and trying to work harder really had to let go of that. And so that kind of spiritual integration into psychiatry, into mental health, was an interest as well. This was my first job, my first paid job, working in a psychiatric department in a large community not-for-profit general hospital run by the Seventh-day Adventists, which is what I was raised originally. And so it was an Adventist hospital, and we had an inpatient program as well as outpatient. And then a few years later, we took that team that I was working on, the addiction treatment team, doubled its size, moved it to another floor, and I started up and directed a 21-day, 16-bed, 21-day hospital-based addiction treatment program in the context of the psychiatric department, in the context of a community general hospital. And it was about that time, 1981, that Blue Cross said you shouldn't have these fixed programs, 21-day hospital-based program, which was because there was a mandated benefit for every citizen of Massachusetts for 30 days of hospital level of care, and a mandated outpatient benefit of just though $500 a year. So we developed a 21-day hospital-based program because that left over a few days in case they relapse. A very scientific way that we developed our program, and Blue Cross said you shouldn't be having these fixed programs. We got mad and everybody tried to get the legislature to change it, but it got me thinking, as a physician who there's no fixed length of stay for any other disorder that we treat, the path that has really shaped my career from that time around looking at criteria for levels of care and for individualized treatment. The field has still struggled with moving away from a program-driven method towards what we do for every other illness. But that was the beginning of my journey, being forced to look at that and to challenge my still pretty new experience in the addiction treatment field at that point, really just 4 years, but very early on because of the really advances of Massachusetts to start thinking more even back in the 80s about more individualized treatment. Now I do a combination of things. For nearly 20 years have been working in training consulting, so I'm probably more of a teacher and consultant than I am a direct care. The main patients I see are in consultation, case conferences, as I go around different programs that I'm consulting with, but also doing a lot of teaching, workshops, consulting, and doing some of my work with the Change Companies, which has had a long experience in working with interactive journaling, which is a process of guided self-change process with patients and clients. Well, I think in the United States, a constant is the passion of recovering people being involved in treatment at every level, on the front lines of counseling and in terms of developing programs, and certainly recovering people with means, starting up and funding programs. So a constant of 12-step, abstinence-oriented, kind of passionate life experience driving the addiction treatment field in a way that has given it a soul and an outreach that you don't see in any other illness. I think that's sort of a bit more unique to the United States, I think, than Europe, Australia, Canada. But that I think is a constant in addiction treatment. Remember some years ago visiting an injecting clinic in Sydney, something you would never see in the United States. You will see it in Vancouver, Canada, but people can bring their own drugs to the clinic and get clean needles and get some nursing care if they have infected wounds, and get some counseling to try and engage them. They can shoot up with other people there, but they can't hang out there all day. So that was fascinating. But Australia, Canada, UK has been much more focused on harm reduction, public health interventions, less so around abstinence and overall recovery, although of course some programs have taken on a more US model of treatment. I come down on individualized treatment, which means that some people who obviously have crossed the line into addiction are going to need, for the best outcomes, to be abstinent. There'll be other people who may not have a severe addiction problem, who, if they aren't interested in abstinence, I would want to work with them to be doing whatever it takes to reduce their harm. And then, of course, there's the public health version of harm reduction, where you maybe not even worried too much about people being in recovery. Of course, you wish that they would, but for public health reasons, you're going to continue them on maintenance medication or other kinds of things. But the real issue for me is, even if somebody clearly should be abstinent to get the best outcome, but if they're not there yet, then I would want to work with them in a progress, not perfection manner. And so I never really am too concerned about are you abstinence-oriented or harm reduction or moderation management, because you have to start where the person's at anyway, and then work with them to get the outcomes that make sense to them. Well, I think more recently there's been much more awareness and interest from all levels of professionals about addiction as a brain disease and neurotransmitters and the role that medications can play in addiction treatment. There's been more interest, either partly because of people mandating it, but people also trying to grow in terms of evidence-based practices and methods and motivational interviewing, stages of change work, cognitive behavior therapy, 12-step facilitation. So people have, I think, moved from a kind of anti-intellectual doctors are bad medical model to a bit more of a holistic and eclectic in the good sense of the word, but not across the board. I mean, there's still people who are very social model oriented and very still behavioral, but in general I would say people have become broader in recognizing we need a mix of interventions and a broader attitude towards embracing different models and strategies. So when we opened the program, the 21-day hospital-based program in '81, and got beat on the head from third-party payers, that got me thinking. Same thing happened in the mid-'80s in the Cleveland, Ohio area. And that really was the beginning of the journey of the ASAM Criteria, which were first published in 1991. And of course, I've been chief editor of those since its beginning, so I've seen it through the years of trying to move the field away from program-driven compliance, fixed length of stay treatment to person-centered, individualized, outcomes-driven work with mixed success. I mean, I think some people would say that has had an impact on the field, and then as I look at still many programs describing their programs as, a fixed length of stay program, and certainly on the ground level, if you ask patients and clients, how long do you have to be here? They often have a number in their head because that's what they've been told. So on glass half empty, pessimistic days, I think we've had no impact. On positive days, I think it's had a tremendous impact. And is getting some momentum now with the Affordable Care Act and with increased numbers of people on Medicaid, with Medicaid becoming one of the largest payers now. And as the Center for Medicare and Medicaid Services says, how are we going to handle these extra people, especially in addiction treatment? What's exciting from the ASAM Criteria's point of view is the waivers that they're offering states to apply for to revamp their services in conjunction, in consistency with the ASAM Criteria. So now we have some states that are interested in the ASAM Criteria from a need-to-know level, not just a nice-to-know. And even though we had 25 to 30 states who said they used them over the last decade or so, using them meant lots of different things from different people. But I think we're getting to a point now where there's an opportunity for a bit more consistent, standardized implementation of the true content and spirit of the criteria. One of the, I don't know if it's a breakthrough in the addiction field, but some of the changing culture things as we move from a sick care system to a health and wellness system where we're paid to keep people well instead of, benefiting from people being sick. This is going to increase the momentum for people to take addiction seriously and to look at what we should be always doing, managing care and being good stewards of resources and making resources stretch as far as possible to get the best outcomes. And so those things are coming together now between the healthcare environment and the financing system and what we've been trying to do with the ASAM criteria for many years to really create a system that manages care in the most effective and efficient way. I think they're consensus-based in their initial iteration. David Gasperin, for a decade, devoted his career to research on the criteria to move it from a consensus document to some evidence base, and with $6 or $7 million of money from the Center for Substance Abuse Treatment and NIDA and NIAAA, really was successful, I think, demonstrating the validity of matching people to levels of care, and that there are problems if you overmatch. In other words, put somebody into a more intensive level of care than they need. There's troubles if you undermatch. And I think demonstrated pretty well the validity of multidimensional assessment, continuums of care, and matching people in that way, with the criteria being probably the most studied, researched, and certainly in terms of dollars, criteria around. So I think we have an opportunity to move even more empirically with now the release of a standardized assessment now called Continuum, where if we could ever get to the same as a cancer registry where we have thousands of standardized assessments, we can move to be even more empirically based, I think. Compared with, say, a more program-driven model, you have to complete 28 days of our residential, then go to aftercare and complete our 6-week IOP program and so forth. Not only, I think, is that less efficient, but it's too gross a match to be able to get the more individualized outcomes that a chronic disease model in a flexible, seamless, and efficient continuum of care, which is really what the ASAM criteria is trying to do, no different from disease management of any other disorder. And so I think we will get better outcomes and have better efficient use of resources. We do it with every other disorder, so why not addiction? Well, I'd like to see us take addiction seriously as a chronic disease, and to look at learning from what we know about chronic disease management and really bring that to addiction treatment. Because even still, everybody says that we believe addiction as a chronic disease, but then treat it as a sort of a segmented program, episodes of care, we really speak out of both sides of our mouth. For example, for no other disorder do you discharge somebody for having a flare-up of their illness, and yet even it's not the ignorance of the general public. Even addiction treatment people struggle with their ambivalence. Nicotine addiction kills more people than World War II, the AIDS crisis, and some illicit drugs every year, and yet a number of addiction treatment programs still have the gazebo for the smoking, when we don't have a heroin gazebo and a beer gazebo and a Xanax gazebo. So even in basic addiction treatment, we are ambivalent about addiction as a disease and as a chronic disease. If we really embrace that, that would start influencing how we design, deliver, and pay for a continuum of care, and it would influence policies when people have flare-ups and have a need for continued treatment around a slip or a use. What's happening in all chronic disorders is to move away from crisis stabilization and management of symptoms to health and wellness, not just because people are being nice, but because that saves money. So when we talk about recovery, which addiction treatment is talked about more for longer than mental health, and really has talked longer than in physical health disorders, I think all of healthcare is moving towards seeing the importance for the outcomes of wellness in physical, mental, and addiction health. So it's in the best interests of payers to start moving the payment incentives towards population management and paying for wellness than it is to be paying for acute stabilization of crises and flare-ups and exacerbations. There'll always be acute exacerbations of any disorder, and you do want them to be fewer and you want them to be less severe. And the way you do that is to move all people towards wellness. Wellness and addiction you can see as being somebody who has a life beyond their diagnosis, who can achieve well-being according to their values, their culture, to their abilities. So wellness for Elton John may be being a fantastic singer and writing more songs. Wellness for somebody who may have less initial talents might be getting a job, and for other people it might be not being homeless anymore. So it's in relationship to their abilities, but how do people reach their full potential physically, mentally, spiritually, and socially in a way that's meaningful to them in the context of a culture and a society that can bring some degree of serenity and happiness. I think it's an outdated term, especially if people link that with as long as you're abstinent and going to AA and not getting arrested and not having detox episodes or something. And that if we broaden that to wellness, I think that captures better something that is more person-centered around a more attractive direction to move people. And that's on the sort of personal satisfaction level. On the cultural and on the financial level, that's going to help save money as well. And so in the latest edition of the ASAM Criteria, we raise that may be a term that's had its day, and that it's not a meaningful term, because if you ask addiction treatment people, does a relapse start when a person picks up a drink or a drug? They say, of course not. It's a process that started way before. Well, when did it start? The second after the last drug use, or 6 months later, or so William Miller of Motivation Interviewing has said that's a meaningless term. You can't study it because you can't define it, when it started, and so forth. And we don't say if somebody gets suicidal, you've had a relapse, or if somebody's blood pressure goes up, you've had a relapse. We don't usually use that term for pretty much any other illness. Acute exacerbation, a flare-up, reoccurrence of signs and symptoms, those are more meaningful terms that cut across all disorders. Yeah, and anyway, you can't strictly have a relapse if you haven't been in recovery. You know, you first have to think you have a problem, wanted to stop, did stop, got into recovery, from which you relapse. But it's a term that I think is going to be hard to disappear, but I think it's time to move on from that. We're just getting started on that, of the integration of addiction and physical health, because it's critical when you look at the Substance Abuse and Mental Health Services Administration's National Survey on Drug Use and Health that they put out every September. You know, the roughly 23 million people 12 years and up who have addiction problems, but a tiny sliver of those get into addiction treatment, maybe 1.5% or something. So you have a large proportion of people with addiction who either don't know they have a problem, or if they've been told, don't think they have a problem, who then never reach out for treatment, but nevertheless cost money in general physical health, in mental health, in social problems, in the legal system. So we're paying for addiction illness in many sectors, but not treating the primary disease itself. So as we take a look at healthcare costs and social costs, it's inevitable that we have to bring addiction treatment much more integrated into physical and mental health, because that's where the customers are. And that means we have to bring it into there rather than to give them a number to call, something which they won't do and haven't done. And so that brings together more holistic care for a lot of reasons, and I think we're going to see more and more of that as people pay attention to what it costs them. Mm-hmm. To treat them. They always knew that, but there was no financial incentive to do anything about it. Now there is, because if you get dinged for readmissions within 30 days to a hospital, now you're very interested in who are coming back, and that's 60% of the people are coming back. Now you get very interested in addiction treatment, in continuity of care, in working with the family, in care management, all of the things we should have been doing anyway. When you don't have that emphasis on a more holistic care, it perpetuates an attitude that it's not important to do that. And when in the past the financing system has not disincentivized that, but that's changing, both in terms of incentives to more healthy lifestyle, cultural attitudes about it, and then the healthcare system itself. So we're moving in the right direction, and I think it's the same message across all illnesses. I think if we wait to train people, you're still up against societal attitudes. So there are some people that have addressed this more by saying, we're going to bypass training people, doctors and nurses, to assess. We're going to look at codes of who comes into general hospitals, what disorders indicate addiction, and bypass the sort of human element and start zeroing in on who are the high utilizers, and to get to addiction in that way, because you are up against attitudes, teaching people screening and brief intervention and so forth, which we still need to do, but there's quicker ways, I think, to start identifying the people rather than training people to identify them and then get them into treatment. So, for example, the couple of nurses who I was speaking about who are responsible for having people not come back within 30 days start looking at the population, and they say, there's 60% of our people have addiction. Now they're doing and identifying those people not because everybody's now getting an assessment on a screening instrument, but because you're getting through the door of who is costing us most, what diagnoses are addiction related, and then we're identifying people in that way. So it's got to be a combination of things. It won't be just training people, because there's so many attitudinal issues about and against addiction. Been influenced by Scott Miller's work in terms of looking at client-directed, outcome-informed work, or what he now calls feedback-informed treatment, and 40 years of research in terms of psychotherapy and change. And yes, the quality of the therapeutic alliance, I think, does, from what we can see in the evidence, contribute more to the outcome than the evidence-based practice or the technique and model used. There's a lot of emphasis these days on fidelity to evidence-based practices, and yes, you want to have your best tools in your toolkit, but it's only as you use those methods to generate a self-change process that people with addiction, people with any illness, are going to do whatever they want to do. And how they're going to make the right decision in the dark of night when nobody's watching. And that means you have to really develop a self-change process. And the Therapeutic Alliance, as Scott Miller and others would define it, is agreement on goals, agreement on methods within the context of a working, trusting, mutually respectful, empathic relationship. Many programs work on abstinence and sobriety when the person's working on getting their kids back or staying out of jail or keeping a job, and then work on methods of 90 AA meetings in 90 days and abstinence, sobriety, change your friends when the person has no interest in changing their friends and doesn't like AA. There's no therapeutic alliance, and the likelihood of a good outcome goes way down. So engaging people in a self-change process with a focus on the therapeutic alliance, creating a sense of hope in the context of using the best practices that you can, but in the service of the alliance, not in the service of fidelity to a model, is the combination of those things working towards a good outcome. So yes, medication is time to have medication be in the toolkit of addiction treatment. And some people need medication, some people don't. Some people need it for a short time. Some people need it for a long time. Some people may need it indefinitely. Other people... the problem often, though, with medication and addiction treatment is that treatment providers have not done a good job of the psychosocial other aspects of wellness, and give medication and addiction treatment a bad name because people see people over-medicated on methadone or diverting drugs or selling their medication because treatment providers aren't doing the best around readiness to change and relapse and cravings and so forth. Mm-hmm. So definitely we need to have medication and addiction treatment, but we also need to make sure it's holistic care and that people are getting a full focus towards recovery, not just bio-treatment in a biopsychosocial spiritual disorder. I don't think medication in any disorder should be the first line. In other words, if you can get your blood pressure under control by losing weight and starting an exercise plan and stopping smoking, I don't think we should give medication. If you can get help with your depression through CBT and relaxation and doing some other things and exercising. In other words, I think we should always do the least intensive, least invasive intervention as we do in all disorders. Nobody gets a mastectomy if you can safely have a lumpectomy. Nobody, has their whole colon cut out if they can just have a piece cut out. And medication has a role to play, but it's not a first line intervention any more than in any disorder. There is a role for medication addiction treatment for acute withdrawal management, which I think that would be one example where there is. So, yes, if I was a payer and they said, we've got this person in withdrawal management, we're going to go through social model and that we're going to spend 3 months to do that. That might be no efficient, it might be dangerous, and then end up costing me more if they have a seizure or something. So in that case, medication would be an important part for many people's treatment first off. But short of that, it would be looking at how's a person doing in terms of craving, how's a person doing in terms of management of withdrawal. And it really takes an individualized assessment of, is this a person with chronic opioid use disorder who's had many treatments in abstinence-oriented programs, who has never been successful with that methodology and is coming in again in withdrawal